The history of surgery is a testament to human resilience and the relentless pursuit of progress against disease and injury. For millennia, surgical intervention was a desperate measure, undertaken only when all other options had failed. This was the era before the advent of effective anesthesia, a period stretching from the earliest recorded medical practices up until the mid-19th century. It was a time when the very thought of surgery instilled profound terror. Surgical procedures were not merely medical treatments. They were terrifying ordeals of unimaginable intensity. Patients faced the prospect with dread, knowing the agony that awaited them. This period is accurately described as a brutal reality. The starkness of the operating room, often little more than a table in a public space, underscored the harshness of the procedure itself. It was a time defined by unimaginable pain and suffering. The patient's conscious experience of the surgeon's knife was the central, inescapable horror of the process. The primary and overwhelming challenge of surgery before anesthesia was the excruciating pain inflicted upon the patient. There was no effective means to dull the senses or render the body insensible to the trauma. Patients undergoing even minor procedures were fully conscious throughout the entire process. They could see, hear, and feel everything that was being done to them. Because of this, surgeons were forced to work with extreme speed. The faster the operation, the less time the patient had to endure the agony, and the less likely they were to succumb to shock. Precision was often sacrificed for this expediency. The need for speed meant that delicate manipulations were difficult, and the focus was on completing the task as quickly as possible, sometimes in mere minutes for major amputations. Operations were performed with a chilling lack of ceremony. The focus was solely on the task at hand, often amidst the sounds of the struggling patient and the hurried instructions of the surgeon. Procedures frequently relied on brute force, holding the patient down, applying tourniquets, and making rapid incisions required physical strength and determination from the surgical team. Ultimately, the success of the operation, in terms of the patient surviving the immediate procedure, relied heavily on the patient's ability to withstand the sheer agony. Many simply could not endure the shock and pain. Examples of common procedures included the amputation of limbs, the removal of external tumors, and the setting of complex fractures. Each was a test of endurance for both patient and surgeon. Patients were inevitably screaming and struggling during surgery. Their natural reaction to intense pain was unrestrained, making the surgeon's work even more difficult and harrowing. The tools of the trade in this era were remarkably crude by modern standards. They were designed for function and speed, not for precision or sterility. Instruments included large, heavy saws for bone, sharp scalpels for tissue, and various forceps for grasping and manipulating. Their appearance alone could inspire fear. Crucially, these tools were often unsterilized. The concept of microscopic pathogens causing disease was unknown or not widely accepted. Tools were frequently reused from one patient to the next without cleaning beyond a simple wipe. Blood and tissue from previous operations often remained on the instruments. The use of unsterilized tools directly led to rampant infections following surgery. The operating environment itself was often unsanitary, further increasing the risk. A fundamental lack of understanding of germ theory meant that the cause of these infections was a mystery. They were often attributed to bad air, imbalances in humors, or other incorrect theories. Post-operative infections were incredibly common. Almost every patient faced a significant risk of developing a severe infection in the days following their procedure. These infections were often a fatal consequence. Without antibiotics or a grasp of sterile technique, infections frequently spread unchecked throughout the body. Patients faced a high probability of developing sepsis, a life-threatening condition caused by the body's overwhelming response to infection. Sepsis was a frequent cause of death. They also faced the high probability of gangrene, the death of body tissue due to a lack of blood flow or severe bacterial infection. Gangrene often necessitated further, equally dangerous surgery. Patients faced numerous other life-threatening complications, including blood loss, shock from pain, and organ failure, all exacerbated by the lack of pain control and sterile practices. Surgeons in this pre-anesthesia era were viewed with a complex mixture of fear and respect. They held the power to intervene in life-threatening conditions, but their methods were terrifying. A surgeon's skill was primarily measured by their speed. The ability to complete a complex amputation in under a minute was a mark of a master surgeon, minimizing the patient's conscious suffering. Skill was also measured by their ability to withstand the immense emotional toll of performing such brutal procedures on conscious, screaming individuals. It required a certain psychological fortitude. Surgeons were often self-taught, learning through apprenticeship and observation, rather than formal medical school training focused on surgical techniques. Knowledge was passed down through practice. Little formal training in anatomy or physiology was common among many practitioners. Understanding of the human body was often based on limited dissection experience and historical texts, not detailed scientific study.